Good morning, everyone, and thank you all for joining us today. And welcome to this webinar organized by the Young Scientist Committee of the VPH. Today, we are going to explore how in silico biomechanical tools can support the diagnosis and treatment of spinal disorders by bridging clinical expertise with computational research. So briefly, my name is Linda Carpenedo, and I'm a member of the Young Scientist Committee, and I am a PhD candidate in bioengineering at Politecnico di Milano. And to guide us through this topic, we are honored to have two experts of the field. So first, Dr. Riccardo Cecchinato, a spine surgeon at Galeatti Sant'Ambrogio Hospital in Milan and a researcher at the Università degli Studi di Milano. Dr. Cecchinato is a prominent figure in this field, specializing in spinal tumors and deformities, and is a key contributor to international research, including his work with Eurospine and the AO Spine Board. We are also joined by Professor Luigi La Barbera, Associate Professor at the Politecnico di Milano. His work is at the forefront of biomechanics and patient-specific modeling, with a focus on spinal devices and the development of advanced techniques for deformity correction. So the session will proceed as follows. So first, Dr. Cecchinato will start by outlining key spinal pathologies, current treatment options, and the clinical challenges that still remain to be solved. Then we will hand the floor to Professor La Barbera, who will present the innovative biomechanical modeling solutions developed at Politecnico di Milano to address these very complex needs. So before we begin, just a few very quick housekeeping notes. Your microphones and webcams are visible currently, but they will be enabled during the final Q&A step. If you wish to ask a question, you can simply raise your hand and we will call on you, allowing you to turn on your camera and microphone. Alternatively, you can use the chat at any time to submit your questions, and I will be happy to post them to our panelists for you. So finally, please note that the webinar is being recorded and will also be available online. So without further ado, I would like to pass the floors to Dr. Cecchinato. So Dr. Cecchinato, please, the stage is yours.
Thank you very much, Linda. Hello to you, hello to Luigi, and hello to everybody who's connected here. And thank you to the organizer for having invited me in this really interesting meeting. I hope you're seeing my screen. And I will try in these first minutes of this webinar to address what are the challenges as surgeons we have in planning, correcting, and especially having good long-term results when dealing with adult spine deformity. So these are my conflicts of interest that you can briefly see. None of these are strictly related with the presentation I will give now. So nowadays in our daily activity, especially with the aging of the population, we are frequently facing this kind of problems. So patients in the mid-age or in the elderly age of their life with deformity of their spines. And this deformity could be mainly degenerative, but could also come after an adolescent idiopathic scoliosis that had been conservative treated in adolescenthood, and that during adulthood worsens and becomes symptomatic. So here you see this patient, and in every patient we have to measure the actual situation before the surgery. Why? Because the scientific literature luckily helped us in this kind of patient in finding what could be the targets and the ideal values of these patients. So these are the targets that we want to reach with our surgery. The targets mainly depends on the value of pelvic incidence that you can see here named as PI. And I will show you briefly what we are talking about. So there were beginning some studies in the early 2000s that looked after normal population, asymptomatic population, and that found a really huge variation, especially considering the sagittal alignment, so the lateral alignment of the spine, in terms of the amplitude and the entity of the thoracic kyphosis of the lumbar lordosis. If you can see, for example, this line here, you see that patients that, again, were normally no symptomatic had a value of lumbar lordosis that really changed and ranged between 14 and almost 70 degrees. And for them, all of these values are normality. And the same if we consider the the pelvic parameters like sacral slope, pelvic incidence, as I told you before, and pelvic tilt. Also, these numbers are really variable. And it is quite specific of spine, different from other bones, like, for example, when we consider the angulation of the neck of the hip, of the femur, that is really fixed in human. When we consider the sagittal alignment of spine, the variability is really high. But what is really important are these parameters here. So to go into the details, we measure the lumbar lordosis with an angle that covers from the most lordotic vertebra till S1, and the basis of the spine is the pelvis. And we can measure the pelvis with the pelvic incidence, that is an angle uh, done by two segments. The first segment is a perpendicular line to the end plate of S1, and it's passing through the center of S1. And the second line is a line that connects the center of S1 to the center of the hip rotation. And this is a morphological line because whatever the orientation of the pelvis, this value never changes. So it's a sort of morphological parameter that shows us the basics, the foundation of the spine on the sagittal plane. And there are two more angles. There are the sacral slope and the pelvic tilt that shows the position of the pelvis in the space. So the sacral slope is the inclination of the S1 end plate compared to the horizontal, and the pelvic tilt is the orientation of the line that connects the center of S1 to the center of the hips with a vertical line. It's obvious that these two parameters are positional, no more morphological. So if we retrovert the pelvis, we see a huge increase in pelvic tilt and a decrease in sacral slope. And vice versa, when we antevert the pelvis, we have a decrease in pelvic tilt and an increase in sacral slope. All of these with the pelvic incidence remaining stable. And effectively, the sum of pelvic tilt and sacral slope, this for pure geometrical reasons, equals to pelvic incidence. Now, why are we discussing this? Because we found a huge correlation between pelvic incidence and sacral slope, but especially between pelvic incidence and lumbar lordosis. So the higher the pelvic incidence, the higher the lordosis needed to keep the head of the patient on the top of his or her feet. And this is fundamental because this is the correlation that we want to restore when, in pathological case, this kind of correlation is lost. And you see that, again, pelvic incidence, sacral slope, and pelvic tilt are strictly related each other. Now, based on this, we also see that there are mainly four different kinds of spines, of the sagittal shapes of the spine, depending on the type of pelvic incidence. So we go from spines with a little lumbar lordosis and a short one, and a long kyphosis, like in type 1, up to type 4, where we need a huge lumbar lordosis and a huge thoracic kyphosis, again, in order to keep what we call SBA, that is the plumb line passing through the vertebral body of C7 in a proper position. So at the end of the day, keeping the head on the feet of the patient. And these are two patients that suffer from adult deformities, and these are the two X-rays. And you see that even if both the patients have a pathology of the lumbar spine, both of them behaves differently because in the first case, the C7 SBA is definitively pathologic, while in the second case, the vertical line from C7 is on the head of the hips. What is the difference between the two? Well, both of two have a pelvic retroversion as a compensative mechanism that try to push back the head on the top of the feet. But the second patient has a thoracic lordosis, sorry, while the first patient isn't able to compensate in the thoracic spine, and this makes the SVA, so the C7 plumb line, really positive and really pathologic. And these are all the compensating mechanisms. So reducing the thoracic kyphosis, retroverting the pelvis, and when the pelvis, let's say, arrives at the end of the possible retroversion, the flexion of the knees in order to increment the posterior translation of the head and find, let's say, a definitive balance of the spine. Now, I told you that the balance and the, let's say, relationship between pelvic incidence and lumbar lordosis, especially, is the target of our surgery when we correct patients. And so, if you see this kind of patient here, she came to our observation with a clear deformity because she had 50 degrees of pelvic incidence and only 2 degrees of lumbar lordosis. So, the surgery we did was this. This was a really old case, but here we didn't achieve the ideal lumbar lordosis. If you see, we only obtained 20 degrees of lumbar lordosis with this L5S1 cage and a posterior fusion plus posterior column osteotomies in L3, L4, and 4, L5, while the ideal lordosis of this patient should have been 54 degrees. And you can imagine what happened. What happened was a failure of the implant, a breakage of the rod, and a failure of the grip of the screws in the lower lumbar levels. So what finally we did to solve the case of this patient was doing another surgery, extending the foundation of our instrumentation to the pelvis, but especially doing an osteotomy in L2 that allowed us to correct a lot the shape of the spine and to increase a lot the lumbar lordosis. And we found in this way a good, let's say, result that was similar to the ideal value of the patient. And for this reason, the patient didn't fail anymore. And this is the patient after the surgery. What is PSO? What is this pedicle subtraction osteotomy? Is a surgical technique in which we decompress the spine, as you can see in this image. We remove bilaterally the pedicles, and we remove a triangle of the vertebral body so that compressing the posterior element, we can restore the lordosis. But usually we restore 25, 30 degrees in good hands with this kind of technique. And you have seen from the previous case that sometimes you need even more than that. There are some problems correlated with PSOs. One you can see here on the left. Sometimes to decompress, to see the nerve roots, and to correct properly, you uh, reach the end of the instrumentation with a gap in the posterior spine. And since the final aim of our surgery is the fusion, this kind of gap in the future bed of fusion for our patients for sure can create a frailty point where the fusion cannot occur. And the other point is, as you can see on the right side, so the posterior column discontinuity. So what you see in the books is here on your left, but frequently the reality is what happens here. So a discontinuity of the posterior column, but also the fact that also the anterior column is not continuous anymore because we don't have pedicles there, so we cannot implant screws. And effectively, PSO creates a huge instability in the spine, a really severe instability that has influence in flexion extension, but especially in rotation. As I told you, we instrument this patient with screws, and screws are implanted in pedicles, and we cannot implant pedicles in PSO. And this is another frailty problem. So what we have studied in the past is an option to implant cages above and below the area of osteotomy. But you can imagine that in such a complex procedure, that is this kind of osteotomy plus the instrumentation and the fusion of a long part of the spine, adding a surgical time of implanting cages from an anterior, a lateral, or a posterior way could be something that lengthens the procedure a lot and that can create problems to the patient, mainly based on blood loss. But cages effectively works in a good way in order to reducing the instability of the spine and protecting the posterior metal rods that we implant to achieve the fusion. One alternative to implanting two cages is implanting only one. And we can do this with this osteotomy that we described, that a specific pedicle subtraction osteotomy that's called corner osteotomy. In this way, we remove the pedicle, but we remove also part of the superior end plate. In this way, we create a direct contact between the superior vertebra and the vertebra where we did the PSO, and this means a direct bone-to-bone contact, so higher chances of having a bone fusion. And then we can implant a cage, if we want, in the lower disc that remains the only point of frailty. Like I did in this patient, this is a patient that received previous fusion that failed because of a lumbar mismatch. And obviously here I had the need of doing a PSO. Here I already had a cage in the lower level. I did as you can see here, a corner osteotomy of L3. And in this way, I was able to achieve 66 degrees of lumbar lordosis, having and this is the intraoperative picture, having a direct bone-to-bone contact in the upper level and already having a fusion in the lower level. And if we see some CT scans of this patient having this kind of osteotomies, you can see a nice bone formation at the contact point between bone and bone. Another option we have in, let's say, reinforcing the posterior construct without dealing with the anterior column and implanting cages is dealing with multiple rods. And what we do mainly nowadays is protecting the PSO level with a couple of satellite rods that we can implant in different ways, or following the shape of the sagittal shape of the spine, or in a shape that's quite straight that we call delta rods. Why? Because when we do a PSO, we always overbend the rods, the metallic rods, at the level of the osteotomy in order to connect all the screws. And this creates notches at the level of the rods, the metallic rods, that obviously can be a place of metallic fracture. What we are trying to do in the recent times is doing a different strategy that is connecting the levels above and beyond the osteotomy with two short rods that we don't have to bend, and then doing a fusion of the remaining part of the spine with longer rods that doesn't instrument, let's say, that are not attached to the four screws above and below the osteotomy. In this way, we have shorter rods that are not modeled, that are not bent, and we think this can be an advantage in terms of stability. And the second point is that with this kind of, let's say, technique, we don't have to overbend the long rod to go down to the four screws above and below the osteotomy, but we can reduce the bending of this rod in order to reduce the mechanical stress and increase the resistance of this rod. Because we know that there are a lot of risk factor of mechanical complications, and these that I told you are just a few, but mechanical complications occur a lot in this kind of patient. We have around 45% of mechanical complication occurring in the first 2 years after surgery. This means that almost one patient out of three need to go back to the operating room for minor surgeries. And this is reported in different ways, in different studies. But even if surgery that are not so complex as the primary surgery, we still need to bring back the patient to the operating room. And you see there are different studies showing this kind of values, 40, 45% of mechanical complication. Mechanical complication means rod breakage, means pseudoarthrosis at the level of the osteotomy, but also means junctional problems. And one of the most frequent junctional problems is the PJK or PJF. PJK, proximal junctional kyphosis, means a kyphosis of the cranial part to the instrumentation, so the non-instrumented spine, more than 10 degrees when compared to preoperative measurements. And this has an incidence that goes from 25 to 40%, depending from the statistics and the studies. PJF is the, let's say, bad version of PJK, in which we have the PJK and we had there a fracture of a vertebra, a luxation of the spine, or a failure of the hardware. As you can see in this case of a really bad PJF, where we had a fracture of the last instrument of the upper instrumented vertebra. And there are many ways that we tried in the past years to reduce the risk of having PJF or PJK. One of these is the so-called soft landing technique. So it's reducing a little bit the mechanical stress on the junction between the mobile spine and the instrumented spine using, let's say, less aggressive instrumentation. So not using the screws that instruments the posterior, but also the anterior spine, but using, for example, laminar hook, as you can see here, that grabs the posterior lamina, or sublaminar wires or bands that, again, passes below just the posterior, the vertebral lamina, and has a more, let's say, elastic effect. Even if some studies that we publish, but that are coming out in literature, it seems that hooks and sublaminar bands are not so effective in protecting from PJK or PJF. So to conclude this overview of disasters that we can find when treating with this kind of pathology, we know that mechanical failure in adult deformity is not a single factor event, is multifactorial. For sure, correcting towards the target of surgery based on PI is one of the first preventing mechanisms in order to reduce the rate of failures of the implants. We know that PSO is a frail point of our instrumentation. So what we are trying to do now is using, for example, hyperlordotic cages in the anterior spine when feasible, in order to reduce the number of osteotomy we do in this kind of patient. But for sure, one open problem that still need a definitive solution is the problem with PJK and PJF. So this was what I wanted to tell you and what I wanted to show. I hope that was quite clear. And if it was, I am happy to give the word to Luigi for what I hope the solutions.
Okay, good morning, everyone. First of all, thank you to the Young Scientist Committee of the VPH for having me here. It's really a pleasure and an honor to showcase an overview of almost 15 years experience that in Politecnico di Milano, in my group of in Silico spine, in Silico medicine dedicated to orthopedic and spine orthopedics, we are building and collecting over and over. I would like to provide you an overview of an example where advanced in silico computational models can bring value in basic and translational spine biomechanics. We will see mainly 5 applications. Some of them would be more an overview, some other would be more detailed, especially when related to the first speech that we got from Dr. Cecchinato. In most of them, we will see how computational model can be used as a source of preclinical surgical planning, or also to assist the surgeon and the clinician in the surgeon clinical and surgical decision-making process. Here are my conflict of interest, none of them related really to the content of this speech. The first application is the prevention of mechanical failure in adult spine deformity patient after pedicle subtraction osteotomy. And this is an activity where me and other colleagues from Politecnico, in collaboration with colleagues from Galeazzi, spent a lot of time facing. We already heard by Dr. Cecchinato what are the main issue related to clinical and surgical management of PSO. And here we will mainly focus on the utility of using multiple rods to prevent rod fracture and to understand whether we can somehow reduce the onset of rod breakage, also by using adjacent cages. Me and other colleagues from Politecnico, in particular Professor Villa and Claudio Tardi, spent a lot of time already simulating using finite element models different surgical options using an already validated model representative of an healthy patient with a flat back. We use this model to simulate single, multiple rods, and also simulating the presence of adjacent cages above or below the PSO level, which is here highlighted in red. Through finite element modeling, we could simulate how the stress is arising on each spinal rods. And basically, here you see more details on these papers. So if you would like to read them in details, please do it. We found that multiple rods can reduce the stress and thus reducing rod breakage. But also adjacent cages can be very beneficial in the bringing more loads on the anterior spine. Therefore reducing pseudoarthrosis to a more effective load sharing through the anterior spine. Once this tool, of course, this tool in silico models are very, very complex. So it's really necessary to validate them in order to make them really predictable of what is really useful. So after Claudia Otardi built this model, we spent a while to run experimental tests supported by the Scoliosis Research Society to a fund. And basically, we verified and validated retrospectively, if we could say so, our PSO model, confirming that actually they are really predictive. Once they are validated, we use them for virtual surgery planning to simulate different surgical options with PSO above and below a certain lumbar level, adding and removing rods, shortening or lengthening the instrumentation. And we use it as a purely in silico prediction tool. What we saw is actually that the model predicts lower stress in the same configuration that Dr. Cecchinato was suggesting as the most beneficial, so delta rods with a really short instrumentation above and below the PSO level, bridged by a longer instrumentation. Of course, once we use this kind of model as a purely in silico tool, we must ensure that also what is happening in clinical surgical practice is actually true. And this may come not from experimental tests from cadaveric experiments, but should come from a longitudinal clinical study, which is the only option. So in this case, the only retrospective validation that we can make is more related to a, let's say, prospective cohort that should involve a patient to be recruited. Here, I provided more details on the point-wise validation, where actually we explicitly validated each experimental model by comparison with the corresponding finite element models, and actually we could ensure that it was predictive. But once clarified the role of multiple rods and adjacent cages, which are surely beneficial in reducing the stresses on the spinal rods, can other biomechanically relevant factors play a role? Can yield play a role, since we are contouring the spinal rods above yielding, or maybe mechanical fatigue is relevant? Well, we performed a lot of experiments and validated finite element models, which coupled finite element models and fatigue prediction criteria to really predict whether or not a contoured spinal rod, contour with different techniques, with the French bend, which is typically used by Dr. Cecchinato, or uniform contouring, which is more used during industrial preforming, can affect the actual stress of the spinal rods. We ended up with a nice tool to predict and to interpret how, at the lordotic level, the residual stress is superposed with the actual bending moment due to the body weight and the everyday activities, therefore justifying why lordotic rod breakage is so frequent in this region, which also help in further clarifying how this delta rods is more beneficial. If we bend less the spinal rods, especially at PSO level, where we have a very hard and severe instability, therefore we can reduce the residual stresses, and then we can prevent rod breakage. So this is an example where finite element model can provide benefits to optimize the surgery. The second case directly links to the prevention of proximal failure in a spinal deformity patient using posterior tethers in collaboration with Dr. Cecchinato. We already got why we are interested in this issue, and with Dr. Cecchinato, we figure out how to make, let's say, the adjacent loadings less severe, and we ended up with an option to use laminar bands or tethers as a soft landing, so a non-fusion dynamic device that can be used above the instrumentation in order to smoothen and stiffen the transition, to support ligaments loading, decreasing the loads, and also to provide the primary stability. During my postdoc in Montreal, I also spent some time using some dynamic model where the vertebrae are modeled as undeformable bodies, and we were able to show that the proximal junctional angle can be controlled, tuning the postoperative alignment. And as we increase the tensile loads on the tension band, then we can increase and reduce the proximal junctional angle. Moreover, we can also see that having a smoother transition at the level above the upper instrumented vertebrae, then we can also reduce the moment on adjacent disc, which may justify how PJK and PJF occur. Moreover, we also found that the loads on the adjacent segment is mainly controlled by parameters related to the mechanical behavior of the disc, and also of the stiffness of the rods, which is something that also finite element model can predict. But also the screw insertion level play surely a contribution. The main limitation of such models, however, are that they cannot predict the loading ongoing on the soft tissues, and we wanted really to elucidate whether these soft tethers can be an option, the same as in posterior vertebral body tethers in adolescent idiopathic scoliosis, to prevent PJK. So in order to answer this question, we used in silico models and a parametric CAD model generator to answer this question. We used our parametric spine model generator established in Milan, where we can build a thoracolumbar spine model, including the rib cage, and now also including the sacrum and pelvis. Using this model, we can really design different physiological sagittal profiles to explore different options, different tools within the physiological, but also outside the physiological range, and also controlling pelvic incidence, sacral slope, lumbar lordosis, and thoracic kyphosis. To face this issue, so to answer the question that we posed at the beginning, we designed 3 different spinal profiles with an increasing sagittal alignment from 30 to 60 degrees. And then we had to validate this intact model, both under pure moments and both under axial compression. And here we had to validate those models to predict primary stability and load sharing, so in terms of intradiscal pressure. Each tissue was therefore stepwisely calibrated, adding everything single tissue and ensuring that the continuous description of his mechanical behavior was really caught and well described by the model. So you see that moving from right to left, we had to increase a specific soft tissue or spinal structures, finally leading to a decrease in terms of stability, the same as we have in flexion, extension, lateral bending, and axial torsion in vitro tests on cadaveric spines. This is also confirmed on other functional spinal units at other thoracic levels. So we were happy about the mean prediction error, and we found that this was acceptable compared to experimental dispersion that is anyway much higher than the dispersion we saw computationally. Regarding the kinematics, we observed a slight stiffening effect, so a small decrease in terms of range of motion with increasing kyphosis. And we found that a follower load of 400 newtons is good to fit the experimental range, although we saw also a slight stiffening effects with increasing kyphosis, which can be considered anyway rather low. We simulated 3 instrumentation techniques. I compared a short posterior dynamic tethers at the level T8 and 1 level above, with another longer posterior dynamic tethers from T4 to T8 versus a standard posterior fixation as typically done in surgical practice. The mechanical behavior of the posterior tethers was calibrated based on the side test from literature to get his mechanical behavior. These instrumented models were loaded under complex loadings, so we had to apply the attentional force on the soft tethers. Then we applied a follower load of 400 newtons at a bending moment, quantifying the primary stability in terms of range of motion, load sharing through intradiscal pressure, and the strains on the soft tissues, both on the spinal ligaments, intervertebral disc, to quantify the load sharing, and also assessing the safety of the device. When considering focal kyphosis, we observed that kyphosis correction can be increased with tether tensioning, with a correction up to 5 degrees, which is kept quite constant also after standing and when the functional loading is applied. Almost the same as applying a fixation plus intraoperative compression. When coming to the primary stability, we observed that tether tensioning provide more effective primary stability, and without tensioning, we have a 50% range of motion reduction. While when tuning tethers tensioning, we can achieve a really tunable primary stability. And here you can see that less than 20% correspond to really strong, hard, severe fixation. In all these conditions, the maximum tensile force on the tethers was in the safe range, so well below 50% of failure. When seeing the intradiscal pressure, we saw that tensioning, we have an increase in intradiscal pressures. Then, considering the strains from anterior to posterior, from the anterior to the posterior column, we observed that tether tensioning reversed the strain on the ligaments. So during the intraoperative correction, we see a tensile load anteriorly and a compressive load posteriorly. And after the application of the functional load, we basically see that the posterior spine no longer works in tension and is reversed to compression, as well as the anterior column doesn't work in compression, but it is reversed to tension, especially when the tensile force is really high, 200 or 125 newtons or above. When using multiple tethers, we also observe that thoracic correction can be enhanced with a maximum kyphosis correction of 15 degrees, which can be achieved also with mild tether tensioning, supporting the effectiveness of this technique, and also confirming that the primary stability is good and higher and lower compared to fixation, because we have a dynamic load which can go on the soft tissues. So the take-home message here is that the validating in silico biomechanical models provide comprehensive quantitative biomechanical insight to support the safe and effective use of posterior tethering in hybrid instrumentation for adult spine deformities. We use these models also to study the effect of lordosis and instrumentation technique on adjacent segments, on a shorter fixation with the short rods, again using our validated spinal model. Here we generated 3 different sagittal alignments from type 2 to type 4 with an increased lordosis. And here we simulated a simple short fixation and without or including a fusion at the level of L4, L5. Again, we applied complex loading and quantified range of motion, intradiscal pressure, and principal strain on the soft tissues. The fixation reduced the loads on the instrumented segment, but further fusion decreases the ROM within the instrumented segment even further. When considering the adjacent segment, we didn't see any adjacent level effect, probably due to the hybrid loading applied, which can be discussed as a similar effect as found in vivo by some people in the literature. Considering intradiscal pressure, we saw a slight decrease in terms of intradiscal pressure with fixation, which was expected because we have a stress shielding effect. But fusion further decreased the intradiscal pressure at the fused level as expected. And again, no effect on adjacent level could be found. When considering the soft tissue, we saw that for both instrumentation condition, fixation and fusion decreases strain both on the anterior and posterior spine within the instrumented region, which can be related with the strain shielding. And of course, fusion is much more effective in further reducing the stress at the below the upper instrumented vertebrae. While above, we can say that fixation and fusion do not impact strain on adjacent segment, probably due to hybrid loading configuration. Since we cannot answer this question using hybrid loading configuration, we wondered how and why complex loading could be needed to study adjacent segment. Therefore, together with Linda Carpenedo, we are now building an integrated musculoskeletal model, fully integrated in a finite element deformable model, in order to better understand how the boundary condition on the spine can be improved. This paper is newly published. Briefly, we built a simplified architecture of the lumbar spine, including the abdomen with the main local and global muscles. We validated the muscle activation pattern, which showed both in standing and up to 20 degrees flexion, reliable trends with increasing basically muscular activation in the abdominal muscles as we go from standing to flexion, and an increased in intradiscal pressure, the same as in vivo and in silico data. Moreover, this deformable finite element-based musculoskeletal model can provide a lot of information related to the anterior posterior load sharing, which is the main advantage compared to current multi-body models. And we can appreciate the loads on the intervertebral disc here in light blue, on the anterior and posterior longitudinal ligaments here in dark blue, but also in the facet capsules and on the posterior tension bands, so flaval, interspinous, supraspinous, and intertransverse ligaments. Here you have an overview of the load sharing. Very quickly, compressive forces and bending moment tends to increase from standing to flexion, as you can see here, and shears tend to shift anteriorly when passing from standing to flexion, both cranially and distally. When representing more quickly the internal loads on their spine, we can clearly see that the disc bears most of the compressive and shear loads in standing, which is the same as in multi-body models where the intervertebral disc is simplified. But we could also appreciate that the facet capsules bears a significant amount of the compressive loads and most of the bending moment, especially in flexion, highlighting the relevant role of this tissue and the need for a deformable spine model based on finite elements. Of course, we can predict principal strains, and the idea is that this model are really cool, really valid, but they are also very complex. So their validation requires a thoughtful step-by-step validation by comparison with the literature whenever available, but also with in vivo data whenever available. The last application that I would like to show is the use of tissue differentiation model to predict the outcome of lumbar spine fusion, which is often related to subsidence and pseudoarthrosis, as we saw in the first presentation. Here we used our validated spinal model generator coupled with a novel tissue differentiation models, which was developed by Davide Ninarello in collaboration with Professor Anna Isaksson from Lund University to analyze fusion progression after spinal surgery. We used again our validated spinal model generator to build up a T12S1 spinal model and to reproduce a PLIF cage at L4, L5. Here we simulated again a hybrid loading condition with a follower load depending moment and simulated the standalone fusion cage, which is not used typically in clinical practice and surgical practice, which can be considered a worst case, and different condition with posterior fixation at 1 level, at 2 level, and at 6 levels. In all these conditions, we predicted the mechanical stimulus on the granulation tissue, which is here represented in pink, in terms of octahedral shear strain and hydrostatic pressure. Davide had to struggle a bit to build up this new modeling tools for tissue differentiation prediction, modeling 4 cell phenotypes where mesenchymal stem cell can diffuse and migrate inside the granulation tissue and evolves to fibroblast, chondrocyte, and osteoblast depending on the mechanical stimulus and based on Claes and Heigele formulation. So depending on where we are, then the cell activities towards differentiation, apoptosis, or proliferation is triggered. Moreover, 3 tissue types can be created inside the model: fibrous tissue, cartilage tissue, and bone tissue, depending on the mechanical stimulus triggered towards formation and degradation, which then is handled through material properties update in terms of elastic modulus and Poisson ratio. The output that is calculated is bone concentration, bone distribution in 3D, and the range of motion in all these simulated instrumentation conditions. What you can see here is that depending on the follow-up month, this bone concentration increases, and we have these curves showing an increased trend, which is the most beneficial, which is the highest, with a single level standard fixation and fusion at 1 level. Then at 2 level, fixation and fusion with the lumbar interbody fusion, followed by surprisingly standalone cages, and the last one was the 6 level instrumentation. Here an overview of what is happening at 1 month, at 6 months, and 12 months, where you can see here how the granulation tissues is stimulated towards the formation of bone disc concentration. Finally, we have also a 3D map of the bone formation. Here you can see in black, from black to white, newly formed tissue with an elastic modulus above trabecular levels, meaning white, meaning very high density, very stiff bony bridges. We can see that the single level posterior fixation triggers high density bony bridges, which is beneficial and confirms why in clinical practice this is considered the standard. In 2 level posterior fixation, we see that in some spot highlighted here in red or yellow, the density is lower or totally absent, while no bony bridges was observed in the standalone fusion, especially anteriorly and posteriorly, while in the middle, in between the cages and in the whole of the cage, we saw a low density elastic modulus. Surprisingly, the long fixation didn't show any bony bridges anteriorly, but also inside, and we saw a slight shift of posterior bony bridge formation. So we questioned also the primary stability of these models, and we clearly saw that at the level of the fusion, the primary stability is the best when using a single level fixation. While in the other cases, we have on the standalone fusion an excessive mobility, which justify why we have an excessive mobility and a low stimulus, which doesn't trigger a bony bridge formation. On the other side, we have a 6-level instrumentation with fusion, where the loads are reversed toward extension and doesn't trigger a good bony bridge formation anteriorly because we have extension. Therefore, we can confirm using this model that the single-level posterior fixation is the best trade-off between stability and stimulus to reach fusion. So this is an example where a novel tissue differentiation model can be used as a promising tool in pre-surgical planning, but could be also used as a post-surgical follow-up to follow the patient and to, let's say, calculate the risk of pseudarthrosis or lack of bony bridge formation in advance. And this could be used also as a tool for clinical, let's say, prevention and to foresee any adverse complication before it even shows. But of course, also in this case, as the model is very, very complex, we need a clinical validation, which can only be performed or against a very detailed clinical series or as a prospective base. I would like to thank all the colleagues, the PhD candidates, master students, and external collaborators who contributed to this research, and also the funding body who supported my research. And I would like to thank again the VPH organizers and take any question. So thank you.
Okay, so thank you very much for this presentation. Now it's time for questions and answers. Again, you can either write your questions in the chat or ask them directly by raising your hand. So I don't know if there are any questions. Maybe while we wait for our attendees to formulate their questions, I would like to kick off the discussion with quick questions of my own. The first is for Dr. Cecchinato. So from a clinician point of view, how much do you rely on the results generated by our computational models when making, for instance, surgical decisions? So is there sort of a threshold of trust required for you to integrate the results of our models, our findings into your daily practice?
Well, Linda, thank you for the question. Obviously, I have to say yes. I cannot say no. No, apart from joking, I think your studies are fundamental, because whenever we do this kind of instrumentations, we try always to find new ways when the old ones don't work effectively and enough, new ways in order to increase the chance of the instrumentation to have a life long enough to make the bone and create the bone at the level of the fusion. So having the biomechanical, let's say, studies and tests on our instruments and on the different ways we are able to instrument the spine, I think is fundamental in order to, again, really guide us in choosing the best instrumentation. On the other side, obviously, the models are getting more and more complex, and I wanted to thank you and Professor La Barbera for those studies you are bringing on this, let's say, more dynamic and soft tissue, let's say, evaluation, because again, spine is not a single bone, is a complex of bone, ligaments, disc, muscles, and so it's difficult to understand properly how it functions and how our surgery affects his function. And so I think that the amount of your data mixed together with the clinical data that we can report and we can follow up on the patients are fundamental in finding the right way to again, treat and instrument these kind of patients.
Okay, thank you very much. And as for Professor La Barbera, we know that validation is a struggle. What is your desire? What will be your dream for validation? And do you think that clinician, so the clinical standpoint, could actually help by providing some data from their everyday practice?
That's a really tricky question. Thank you. Of course, validation should, let's say, evolve as the complexity of the biomechanical models is increasing. So let's say nowadays, validation towards primary stability, so range of motion, intradiscal pressure, measurement from sensors, maybe strain sensor on the spinal rods, maybe a sensor on the maybe even electromyographical sensor is essential. Probably validation for next generation spine models will require new technologies. So, or maybe new ways, maybe also derived from clinical images, from MRIs or functional diagnostic from advanced imaging technologies in order to have some information that nowadays we still are not looking at. So probably the most information, the information I would like to have nowadays is not even available because we cannot measure it. So probably we need to sit together, see what is ethical to be performed on patient or on living subjects. We need to advance technologies and for sure sensor and new technologies will be the bottleneck for the validation of very, very complex spine models, I think.
Okay, we have another question for you from our attendees. So, Luigi, thank you for an interesting presentation. In the tissue differentiation model, are you mapping the displacement field from the macro scale model to a micro scale model of implant plus granulation tissue? If not, please elaborate on loading conditions resulting in a local mechanical stimulus. You are muted.
Okay, no, we are not mapping the displacement because we rely everything on a poroelastic modeling and on the mechanical stimulus, which is triggered by hydrostatic pressure and octahedral shear stress. This is maybe a technical question that we can maybe address outside this webinar, and I would suggest I mean, who raised this question to link directly with Dr. Davide Ninarello for that question. But actually, we use the Claesen-Egele formulation, which is well established. So no need for displacement mapping.
Okay, thank you very much. We have another question for Dr. Cecchinato from our chat. So great talks. For Dr. Cecchinato, if a patient's alignment is very far from the ideal spinopelvic angle values, could correcting it all the way back to those targets be too abrupt for the spine, tissues, muscles that are not used to that posture? Could this also have a role on the development of PJK and PJF?
Yes, thank you. It's a really point question because when a patient keeps a position for years, that's given by the degenerative spine. Obviously, also the soft tissues around the spine can have some influence, and so probably there's a retraction on some, let's say, muscles that really can be one of the triggers of PJF. We published a study a couple of years ago that when we correct in a huge way the spine, we have a huge increase of an angle that at the end of the day determines the distance between the rib cage and the pelvis. And obviously the abdominal muscles are there, so we stretch them completely when we increase the lumbar lordosis, and they can really have an impact on, let's say, an anterior tension that tries to bring back the mobile spine to the original place. So for sure, the tissues around the spine, as I told before, spine is not only the vertebrae and the discs that are there. It's a mix of vertebrae, disc, ligaments, muscles around, and obviously the global body balance. It's another topic, because if we bring back the spine and we don't align it properly, probably there is a moment of flexion on the top of the instrumentation that is given by the weight of the body that can also trigger the PJK or the PJF. So it's really a complex matter, But just to add another complexity, also the position we have in our daily life. So up to now, we instrument patients restoring their shape based on studies where the patient is standing. But we know that our patients are standing, let's say, 30% of the day, probably something less. And so when they sit, and again, we published some data on this, they completely change their alignment. And the way we movement their spine also affects the way in which they sit, with a direct influence on the junctional angle. So again, the complexity is not so easy.
Okay, so thank you very much. And regarding spine alignment, again from the chat, we have a question. What defines the optimal sagittal alignment for an individual patient? And is it a universally valid alignment, or is it inherently patient-specific?
Well, the ideal spinal alignment is the one in which the thoracic kyphosis, the lumbar lordosis are proportional each other and are proportioned to the value of pelvic incidence. This is in normal spines. But then there's also an adjustment for age. So there are some studies coming out in which, especially in older patients, a hypocorrection of the lumbar spine can be accepted because, again, it gives less huge correction to the spine itself, less problems of tension on the muscle itself. You leave the patient with a bit of hypolordosis, with a bit of compensating mechanism. But if you look at older patients walking around, they live with compensating mechanism. So probably when we fuse this kind of patient, we can accept a minimal of hypocorrection in order to reduce the invasivity of our correction itself. But
Okay,
again,
so
dictated by pelvic incidence.
no
Sorry.
problem. Okay, so thank you. We have one last question for Professor La Barbera. How accurate is the validation of the muscle integration of the finite element model against ex vivo or in vitro models? What alternatives are used to validate the models?
Okay, this question would be more for Linda than for me, but I will do my best to let's say answer. I mean, musculoskeletal models are typically validated using EMG data, so using sensors to evaluate and assess the electrical activity of specific muscles. If you go back to my presentation, you would see that some data doesn't have any quantification, any let's say experimental validation, because we don't have any available measurement for standing or for the simulated loading condition that we considered. Having an alternative, to be honest. To be honest, electromyography is the standard. Maybe one could think about using MRI imaging. I recently read a couple of papers where they are using some diffusion. Let's say they see how liquids are diffusing inside the soft tissues, and depending on that, they can really have information on how the muscular fibers are oriented and how they behave. Maybe from that we could have some new tools that can be beneficial to validate this kind of very complex models. Linda, would you like to add anything?
No, I actually agree. When I think of validation of muscular forces, I always think of electromyographic measurements. But of course, we are going into new technologies, so I think that maybe some new measurements will come in the next years that will actually be very helpful for our validation process.
Yeah, definitely. I mean, if we can look directly into the input or the cause of having a specific alignment, then everything is better. Otherwise, we don't have. If we don't have any information to validate some part of our complex models, then we can rely only on sagittal alignment from X-rays, from MRIs, standing, sitting, but basically static posture. But again, that sagittal alignment would be a very complex consequence of a mechanical loads, which is due to a counterbalancing of muscular contraction plus gravitational forces, which actually explains from a biomechanical point of view why the spine is aligned that way on the image. So probably we will need new technologies to advance further this kind of model.
Okay, so thank you very much for this presentation and the discussion. There will be so much more to say, but we are running out of time. So I would like to thank our guest speakers again, Riccardo Cecchinato and Luigi La Barbera, for their contribution today. And also a big thank you for all of you who joined us for your participation. Before we conclude, I'd like to remind you that the VPH conference will take place in Milan from September the 1st to the 4th. Registration is open, and please note that special discounts are also available for VPH members. So we look forward to seeing you there. And I hope that you enjoyed this webinar and that you'll have a good day or evening, depending on your time zone. Thank you very much.